We're welcoming this morning Larry Markham from Riley Children's Hospital in Indianapolis, Indiana. I'm so thrilled that you're here, Larry. We've known each other for many, many years, and really pleased that you're going to be one of the leaders in the Dystrophinopathy Clinical Research Network, or the DCRN. This is sort of a new undertaking and very exciting. It's something I think we have all thought about for many, many years of this need. So I'd love to get your take on the DCRN, why you think it's important, and where we hope to go.
Sure, Pat. Thanks. I really appreciate the opportunity to talk about this with you. I think as I look back over our 20-year relationship in Duchenne and dystrophinopathy, I think we have made great strides in really defining the natural history. Unfortunately, we've actually uncovered that cardiomyopathy is a significant contributor to morbidity and death, actually, in dystrophinopathy. And so we've documented some of the risk factors that lead a patient to progression in disease. However, we still have a lot of barriers. As you know, there are 40-year-olds with dystrophinopathy who have relatively preserved ejection fraction, and we have lost 10, 12, 15-year-olds of very significant cardiomyopathy and rapid progression. We still don't know when a boy is diagnosed or a carrier is diagnosed, which group they're going to fall into. There have been efforts with the Duchenne Consortium, with Action Registry, that we can identify when someone is progressing and we can be aggressive with treatment. Action has done a phenomenal job of disseminating information and ensuring that all cardiologists in the dystrophinopathy space are adhering to the same treatment protocols. But we're falling short in being able to stave off the most aggressive cardiac disease. So the opportunity is now, because we have interested parties, invested parties, and people who want to continue to change the outcome.
Yeah, I totally agree with you. I think that we have come a long way, but we're not far enough yet in terms of being able to completely understand. So your hopes for the DCRN are to follow these patients, both carriers and young boys and some female manifesting carriers with Duchenne, and try to think about how to protect their heart function, but also how to add on new therapies. Can you talk a little bit about, I think when we met, we shook our heads and said combination therapies are what's needed. And now we're here with 8 approvals and maybe more coming. How do we get there in a way to know what drug, what sequence, what time, and how to manage all that?
Yeah, I think that has been one of the barriers, certainly, is the cost, the investment in time of these families and research groups into saying, I'm going to sign up for a clinical trial, and 5 years from now, 10 years from now, we might have an answer on if this is effective or not. I think we are just now to the point with all of the invested parties in the DCRN that we have enough knowledge to really put together sort of a go, no go flight plan for specific therapies. I would envision us to have what we have termed a platform trial, where therapy A is investigated for a short period of time for a signal of efficacy, and either therapy B is added on to therapy A, or therapy A is discarded and we move on to B and C in relative rapid sequence. And I think we have been hesitant to do that because there is some scientific rigor that we would like to prove efficacy. But as you and I have talked about, a decade-long clinical trial is not favorable for Duchenne or dystrophinopathy. And if you look at the therapeutic approaches today, it's not uncommon for a boy by the age of 10 to maybe already be on 3 cardiac medications because of our proactive approaches, which have evolved over the last 10 to 15 years. And so I think therapies and clinical trials also have to start with that baseline in place. We can't exclude patients because they're on what we would view as state-of-the-art medication. So the trials have to incorporate what is current knowledge and then build on top of that and not exclude until the point that we have a cure. And then at that point, you can say, well, the cure is the foundation, whether it be gene therapy for skeletal muscle disease, and we will focus on cardiac medications after that. But we have to have that knowledge. We have to have that pace of intervention. And this creates enthusiasm for the community and a platform which we can exist and move forward at a much rapid pace.
Yeah, I mean, I think as we start with 7 sites, I'm hopeful that you all will grow this and that there will be a time when every individual with a diagnosis gets into this system and that you know exactly what to do and when to do it. I think one of the worries today with people receiving gene therapy is what's next for gene therapy when you're on these medications in the beginning and then receive on top of that a microdystrophin. What happens? Where do you go? How do we add therapies? And I'm sure this network, as you're thinking about it, will include those individuals.
Oh, definitely, definitely. And I think one of the things that has come up is the safety around gene therapy and the sites that are participating in this, as well as the sites that are in action already, are really committed to following these patients forward who have received gene therapy so that we know from a state-of-the-art cardiovascular perspective how they are tracking over time. But then, layering different cardiac medications or interventions on top of the existing gene therapy. Hopefully, we can make statements about safety, appropriate follow-up, and monitoring, but then how the coexistence of gene therapy with other medical therapies or newer therapies that come along, that intersection can be done safely, but also in a timely manner. I think it's unfortunate if the thought is, well, you've got gene therapy, now you can't participate in this new clinical trial. I think we have to have an open mind from a scientific perspective and be able to account for those variances in what we might say would be the perfect trial.
Yeah, I don't disagree, and I'm hopeful that there will be a day when you have a group of or a cohort of patients with in the post gene therapy that are amenable to a certain therapy, that company would come in and consider an open label study in that cohort, so you know exactly what the layered on medication would look like, and the reward for the company would be that their label, should they get approved, would be broad to include this group of patients. So I think there's a lot to do, and I can't thank you enough for leading this DCRN. We've known each other for a long time, and I've always been really pleased and happy to be working with you and trusting you and these other 6 sites to take us forward into a new world of Duchenne's and Becker and carrier. So bringing all of your patients to fore so that you can treat them holistically and appropriately. So Larry, this is wonderful. I'm really looking forward to seeing more and watching this evolve. So thank you so much for joining us, and I look forward to the DCRN.
Thank you, Pat. And I can't thank PPMD enough. And I just remember back when PPMD invested in me for a 1-year fellowship to spend time learning and understanding dystrophin and the implications from a cardiac standpoint. There were probably 3 or 4 cardiologists who PPMD could bring together as a group and talk about it. And now we fast forward and we can actually have a meeting of 20 to 30 cardiologists, if not more, who are comfortable with dystrophinopathy, who are active from a scientific and a clinical perspective, and want to push the envelope forward. So that's a tribute to PPMD and your investment and just bringing a community together of cardiologists and really inspiring them to change and evolve. And it's fun and it's exciting.
It is, and we're a very good village together. So thank you so much, Larry.
Thanks, Pat.
You're welcome.